afternoon, everyone. I'm glad you could all make it. We're here to do, as colleague Joe's I did, do a taping of the story of the CCO model. So we're excited to have a three-time former Governor Kitzhaber here, a good friend of BOTUS and a good friend of EOCCO, and his vision of the CCO model and our part in the CCO model is why we've been able to reinvest $300 million back into East Shore. It never happened without the vision of the governor. So we thought it was really important to tell the story of the CCO model and why did we do it. I think you're going to talk a little bit about the prioritized list, right? Why did we do that back in 31 years ago, I guess now. So we're very excited to have Governor Kitzhaber here to tell us the story, capture this, and anything else you want to add, Public?
I just want to say thank you very much. And as a physician, it's always been so important to me that you are also a physician and a local guy and a fishing guy from Roseburg. So I think all that adds credibility to everything that you've done, and we appreciate you.
Thanks very much. I have noticed that everybody's sitting at the back. I want to tell you that I am fully vaccinated. So this is basically a talk that I gave to the Eastern Oregon CCO Conference, and essentially it's just a history of what happened here in Oregon over the last 30 years. So as you know, we've got a long, proud history of health system transformation in the state that dates all the way back to 1989 when we first created the Oregon Health Plan. And for the past 30 years, I think Oregon has been on the cutting edge of innovation. We've been leading the nation in our willingness to question assumptions and to have those honest conversations about the challenges involved with trying to ensure everyone has access to health care in a world of finite resources. I think that today the framework that we've set up over these last 30 years is at a critical point in its evolution, not only because I think we've strayed considerably from the original vision that guided the formation of the coordinated care organizations, both in terms of the rate setting process, but also in terms of the erosion of collaboration that I think is at the true heart of innovation. But also there is some significant uncertainty about the future of one of the key elements of the Oregon Health Plan, which is the prioritized list. And I think it's very important that we maintain that. We've used that to build our covered benefit now for 30 years. And I think of equal concern is the fact that there's, particularly over the last 10 years, there's been an enormous turnover in the leadership of hospitals and health plans and CCOs. There's almost no institutional memory of the debate that went on and why we established these programs in the first place. So for these reasons, I think it's useful to provide a context and a history for the way the Oregon healthcare landscape is in 2025, and hopefully that will provide a basis to inform the coming debate about the future of health policy here in the state of Oregon. So let me start with the story of the Oregon Health Plan. Yes, I had dark hair at one time. When I started my ER practice in Roseburg actually 50 years ago last October, I was 27 years old. I was 4 months out of my internship, and I was terrified about this new responsibility. And what I remember most about those early days, those early years, was how vulnerable these people were who came to see me. They were hurt, they were injured, they were frightened, they were looking for help. And although they didn't know me, they put their trust and sometimes their lives in my hands. It was just this amazing responsibility. And I did everything I could do to help them. I used every bit of technology that I could get my hands on. And even then, sometimes I failed. This was in the days before we had a 911 pre-hospital system, so often that golden hour, right after trauma or a major medical event has come and gone by the time they got to the hospital. So on those occasions when I was unable to save someone's life, I walked across the hall. And the hall ran in from the ambulance ramp and opened on the right to these big double doors into the ER, and on the left there was a smaller room with a couch and some chairs, and that's where the family and friends of people who had arrived by ambulance waited for news of their loved ones. And walking across the hall became almost a ritual acknowledgement of failure for me. I mean, that's what it felt like when I was 27. And I thought it was a long, lonely journey to walk across 30 feet of tiled floor with nothing but compassion and really bad news to tell somebody that their daughter or son or mother who'd come to me for help was gone. And in my experience, that the poignant intersection between mortality and human compassion is one of the most difficult parts of medicine, but it's also that compassion and the humility and the humanity involved is one of the reasons that I went into medicine in the first place. And I'm sure that many providers were moved by that as well. So when in the early years of my medical career, when I was a student here up on the Hill here in the early 1970s, we were taught, and I still believe, that at the heart of medicine is this really, it's a very personal relationship between the doctor and the patient. In a sense, then, healthcare is practiced in a kind of bubble. It's a bubble that encompasses the provider and the individual seeking care, and treatment decisions are made one person at a time, one life at a time, within the vacuum of the bubble, as if there were no consequences outside the sanctity of the relationship. It's the only way you can practice medicine, one person at a time. I would probably have continued to practice in the splendid isolation of the bubble had I not been elected to the legislature in 1978. And for the next decade, I practiced medicine and served in the legislature at the same time. And those experiences brought me face to face with the inherent contradiction between my roles and responsibilities as a physician and my roles and responsibilities as an elected public official. So as a physician, I believed that my responsibility was to the individual patient in front of me and to do everything I needed to do regardless of cost that could help them. As a legislator, you can't ignore cost, and your responsibility is to try to get the greatest health benefit for the greatest number of people with the resources that you have alive. So what I learned is that you can practice medicine one individual at a time, but you can't develop an equitable social policy one individual at a time. The goal is to maximize the benefit across the population. So the contradiction of this, the nature of this contradiction was really brought home to me in 1986 when I was serving my first term as Senate President. And in those days, the legislature only met every other year, the good old days. And in between, the fiscal affairs of the state were run by this 17-member emergency board that was chaired by the Senate President and the Speaker of the House. And they had an emergency fund that was appropriated, and they kept the budget in balance. So in May of 1986, the budget went out of balance by about $35 million, and most of that was due to unanticipated caseloads in the Medicaid program. So in May, at our May meeting of the emergency board, we got together and said, let's rebalance the budget. We took a little money out of the emergency fund, we cut provider reimbursement rates a little bit, and we changed income eligibility standards for the medically needy program and dropped 4,300 people from coverage. And I remember thinking how easy it was. We were sitting in this hearing room in the west end of the Capitol, first floor. Beautiful spring day was going outside. We looked at some numbers on a piece of paper. We took a couple of votes. The budget was balanced. But something about that bothered me, right? To most of the legislators, it's just a sterile budget exercise. So 6 months later, I was back in the ER in Roseburg, and I started to see some people who'd lost their coverage because of the decision that we'd made 6 months earlier, our accounting exercise. And one of them was a guy, I'll call him Mr. Johnson, an early middle-aged guy with hypertension who showed up, came to the ER in an ambulance. His speech was slurred. He had an obvious deficit on the left side of his body, and a CAT scan revealed that he'd had a stroke. This is before we had a formal stroke protocol, so I started treating his blood pressure, got him stabilized, to send him up to the ICU, and called the neurologist who was on duty to come in and do an evaluation. Then I walk across the hall, and his wife's sitting there. She's got her fists like that between her knees and his, but she's rocking back and forth, just obviously in real distress. And so I sat with her. I told her that her husband had had a stroke, that I don't think his life is in danger, but I don't know of the long-term prognosis, and that a neurologist was coming in and would help, and we'll go up and see him as soon as he got there. And I talked to her for a little while, trying to kind of calm her down, and then I began to ask her some questions about her husband, because he couldn't give me any history. So he was working full-time as a janitor at $3.35 an hour, which was the minimum wage in 1986. She was working part-time as a hostess at a restaurant. You know, they were okay. They were not wealthy, but they were comfortable. They made ends meet. In part because, and they didn't really realize it, that their Medicare was, their health services were covered by the state, right? So suddenly, 6 months earlier, he lost his health insurance coverage. He lost access to his primary care physician. He had to pay out of pocket for his medications, for his blood pressure. And their lives hadn't changed. They were still working hard, paying their taxes, trying to put food on the table. And so he stopped taking his blood pressure medication because they needed to balance their budget, right? So when I walked her up to the unit, I realized for the very first time in this kind of rush of emotions that I was just as responsible for his stroke as his high blood pressure. I had participated in an implicit rationing decision to balance the budget and drop 4,300 people from coverage, people that we didn't even know. And I'd walked across the hall many times in that 12 years that preceded that, and every time I'd walked across the hall, I knew that I had done everything I could to save that person. This was different. It was personal. I had basically made a decision that put his life in jeopardy and may leave him with a permanent neurologic deficit. And it wasn't a medical decision, but it was a political decision that had medical consequences. So the next year, in 1987, the Oregon legislature discontinued funding for the Medicaid transplant program, which was an optional program at the time, very small program. I don't think there was, as I recall, there was no specific targeting of that program. It got lost in sort of the larger Department of Human Services budget, but we stopped covering it. It was totally non-controversial. The budget passed unanimously, I think. Unreported, uncontroversial, although it was an explicit social rationing decision. So 3 months later, the legislature's adjourned and this little boy named Kobe Howard shows up. Kobe's 7 years old, his family's on Medicaid, and he's got acute lymphoblastic anemia. And he had been in remission, he'd come out of it, he'd had an exacerbation of his condition, and his pediatrician thought that the only slim chance he had to live was a marrow transplant. So they applied to the state for the procedure, and we didn't cover it anymore. So at that point, his family turned to private fundraising. And this decision we'd made in the legislature, which was non-controversial, became front page news in Oregon and across the country. And, you know, that fall, we all watched Kobe go from this beautiful blonde little boy to kind of this balding waif as the chemotherapy took its toll on him. We had, his mom was on Larry King's show. Al Gore, who was a senator at that time, came out. I mean, it was amazing, a little bit overwhelming, very tragic. And he died in Emmanuel on December 2nd of 1987. They hadn't raised enough money to get a procedure done up at the Hutchinson Cancer Center, which I think was $50,000 at that time. But he didn't have a marrow match, and he wasn't in remission, so it's questionable whether it would have worked. But regardless, it was a human tragedy, and made the more so by the fact we could all see it coming. So in January, at the January meeting of the emergency board, a motion was made by a guy named Tom Mason, a representative from Portland, to partially refund the transplant program for 8 people who had applications pending. And as Senate President, I opposed the motion. And so did the Speaker, who was Vera Katz at the time. And the ensuing debate was viewed by the national media as a debate over transplants, but it was actually a much more fundamental debate. It was a debate about how to allocate limited public resources in a way that was fair and transparent and maximized the health benefit across the population. So to me, the question wasn't whether transplants had merit. They clearly do, often. It wasn't whether we had the money to do 8 more transplants. We had the money. To me, the question was this: if the state was going to spend more money on health care, where should that next dollar go? And what was the policy that would guide us to fund 8 transplants as opposed to 18 or 80? What was the policy that would have us fund transplants as opposed to expanding access to prenatal care? Is one more important than the other? What was the policy that would have us spend more money on health care versus early learning, or housing, right? And what was the equity in taking one group of low-income Oregonians who had access to a very good Medicaid package and giving 8 of them more services before we expanded basic health care coverage to hundreds of thousands of Oregonians, including hundreds of thousands of children who had access to nothing, right? And the fact was that there was no policy. This was a reaction and an understandable human emotional reaction to a very highly visible person, individual in need, but we had no way of determining how best to spend those dollars in a way that would be equitable and would expand the health benefit. So after this, I was telling some folks before here of my experiences on Nightline with Ted Koppel right in the middle of the e-board debate, and then getting on to the Today Show with Brian Gumbel. It was a very difficult and unpleasant time. The motion failed, narrowly failed after this very highly publicized two-day debate. So I was called Dr. Death on the San Francisco Chronicle and Newsweek magazine, and So those two experiences, it was the experience of dropping 4,300 people from coverage in the E-Board decision in 1986, and it was the effort to partially refund the transplant program in 1987 or 88 that led directly to the Oregon Health Plan. So that's a really important context, I think. And so to understand the health plan, I think you need to understand the problem we were trying to solve. So every public resource allocation decision involves three questions. Who is covered for the benefit or service or eligibility? What is covered? What are the services you're paying for? And how much does it cost to get them? How much are we paying the people who's going to provide that service, right? Those are the three. So since you can answer each of those questions in different ways, there are three variables in the healthcare debate: eligibility, benefit, and reimbursement. And because of that hydraulic relationship, there's a cost shift involved. So if you increase eligibility in a zero-sum budget, which the state budget is, if you have a limited amount of money and you have this much for healthcare, if you're going to expand coverage, you have to drop benefits or you have to cut provider reimbursement. If you increase the benefit, you got to cut eligibility and cut reimbursement, or if you increase reimbursement, you have to cut the other two. Those are just cost-shifting mechanisms. If you drop eligibility, it shifts cost to individuals. If you cut benefits, it shifts cost to individuals. If you raise provider reimbursement rates, at some point they'll stop seeing Medicaid patients, and that shifts cost to individuals. So the cost doesn't go away, we just move it around. And the problem we're trying to address is that the legislature was using those three variables. They were manipulating the variables in order to avoid confronting the reality of fiscal limits, and in the process avoiding any accountability for the human consequences of the decisions we were making. That's exactly what we did in 1986 when Mr. Johnson lost his coverage. So the goal of the Oregon Health Plan, this is really important, the goal of the Oregon Health Plan was to create a more equitable and accountable and transparent way to allocate public resources in a way that sought to get the greatest benefit for the greatest number of people with the resources we had available to spend on health care as opposed to education or housing or anything else. And essentially, in its very basic form, it is a budget box and a priority list, right? So what we did, first of all, I remember sitting in my office writing this bill. Senate Bill 27 is not very complicated. You can still find it online. First of all, we put eligibility into statute at 100% of the federal poverty level. Maybe you could argue today that it should have been higher, but that's what it was. So the legislature couldn't manipulate it. That was no longer a variable. We then created a Health Services Commission, and they were charged with prioritizing health services from the most important to the least important in terms of the health benefit for the entire population being served. And to do that, they used condition treatment pairs from the ICD and CBT codes, right? And they prioritized those based on a consideration of clinical effectiveness and social values. That list then was given to an independent actuary who would determine the cost of providing each element on the list, and both providers and consumers had input into the actuarial assumptions, and then that list with the data was given to the legislature. In case of a revenue shortfall, the legislature could no longer manipulate eligibility because it wasn't a variable. They could no longer cut provider reimbursement because that had been determined externally. So they had to decide how much of the list to fund, right? So we changed the debate from who is covered to what is covered. We believe it was better to keep everybody, giving everybody access to health care, make sure they got those things that were the most important, and if we had to reduce something, we'll take a few off the bottom. Now, having said that, and the legislature couldn't change the priority of the list. They just made a funding decision. So we were trying to create a firewall between the prioritization process that we wanted to be evidence-based and public and transparent, and the resource allocation made by the legislature, which by definition is a political decision, right? So the other thing that's really important, and this is where we got a lot of the criticism, the goal of the Oregon Health Plan was never to be a cost containment tool. In fact, we haven't moved the line on the list for at least a decade, probably longer than that. The goal was to first ensure that we use evidence in trying to build our benefit package, which nobody used back in the day, and a lot of people still don't use today. And secondly, to make sure that we wanted to stop implicit rationing. we wanted to force the legislature to be accountable not just for what they funded in the Medicaid benefit, but also for what they chose not to fund. So that was basically the Oregon Health Plan. And with the passage of the plan in 1989, Oregon became the first state in the nation to honestly confront the reality of fiscal limits. If you think about it, states are required by their constitutions to operate on a balanced budget. They can't deficit spend. In Congress, you can push your difficult political decisions into a national debt and leave it for our kids to pay, which is now $35 trillion, up from $13 trillion from Obama left office. It's really big, and it's really troubling. But it was also to create a more equitable and accountable and transparent way to allocate limited public resources, right? And it benefited millions of Oregonians since 1989, partly because we expanded eligibility, partly because we provided better reimbursement for providers, but also because of the nature of the list. What we didn't do in 1989 is we took for granted the delivery system and the incentives in it. We never tried to address the total cost of care, and we never tried to link the provision of medical services to quality and outcome metrics. So all that changed in 2011 when we created the CCOs. So when I took office for my third term in 2011, we were in the depths of the Great Recession. We had high unemployment. We had a budget deficit of about $3.5 billion, one of the highest per capita budget deficits in the country, and over a third of that, $1.2 billion, was in Medicaid. So it became clear that if we wanted to balance the budget, which we had to balance the budget, and if we couldn't get any more revenue, which we couldn't, no one can raise taxes in the middle of a Great Recession, we'd have to either drop tens of thousands of Oregonians from coverage or cut reimbursement by 39%. And those were exactly the kind of cost-shifting tools we were trying to get rid of in 1989. So payers and providers and consumers came together. It's a really stirring story, I think, and I got to be part of it. And they said, we're not going to do that. Instead, we're going to look at the delivery system and see if we can figure out how to get more value for each dollar spent. And the result of that was our coordinated care organizations. And they are community-based organizations with local governance structure. That's what was the original vision. And the idea was to provide top-flight clinical care, but look beyond the clinical model more closely at the community health. They were to operate on a budget that was linked to a sustainable growth rate, and they had to be accountable for quality and outcome metrics. It's really important, and this is forgotten, I think, certainly by OHA today, that the CCOs were built on a partnership, a spirit of partnership and local ownership, that sense of local ownership in operating these things. It was an experiment in collaboration between the CCOs, and the collaboration between CCOs and the OHA was what led to the early success of the program. It was that spirit of cooperation and collaboration. The OHA was a partner in system transformation, right? So in 2012, Obama gave us a waiver, the Obama administration gave us a waiver to use this program to provide care under our Medicaid program. They also gave us a one-time $1.9 billion loan, and it was a loan, to make the transition from the old program to the next program. And those dollars were not given to us to prop up the old Medicaid program, but to create a transition to the new one, right? So the money went down over those 5 years as the savings came up. We committed on our side to a 2% reduction in medical trend from 5.4% to 3.4% per member per year by the second year of the waiver, with no reduction in enrollment and no reduction in benefits, and being accountable to these rigorous metrics around quality and outcome. So I want to say one thing about the 3.4%. That's not magic. People think, oh, 3.4 is the magic number. If you did it today, it would be higher. It's 2 points below medical trend. So if we started today, it would be higher than it is now, right? But the key is to have a global budget that operates below medical trend. That puts the downward pressure on the delivery system. And I want to just go back to that first slide. So what we really did, the genius of this, it wasn't my genius, it was all the people that put it together, is we changed the mix of variables, right? So you got a global budget, so you can't manipulate provider reimbursement. It's built into that global budget. We have agreed not to cut benefits and not cut enrollment. So the only variable now becomes the total cost of care and puts that downward pressure on the delivery system, which creates the incentives to find cost savings, to invest in the community, to reduce the pathology that's coming in the front door. That's the piece, and we'll come back and talk about that a little bit maybe after I'm done in the context of what's going on in Congress right now. The other important thing to remember, though, is that the CCOs originally were supposed to have flexibility in order to meet these metrics and meet these outcomes in a way that, that best suited their community, right? And Oregon was also talking about population health a long time before it became sort of a mainstream event. So let me just go back and remind you that the original vision of the Oregon Health Plan, of the CCOs, was again to look beyond just the clinical model, look more broadly at community health. So this is a tired example you've always heard, but a great example of that kind of flexibility is an air conditioner for somebody who has congestive heart failure and is living in a small apartment. And in the summer, the heat could go up enough in that apartment to put additional strain on the cardiovascular system, and that could lead them into full-blown CHF. So it's much cheaper to spend $400 on a window air conditioner than $50,000 in the hospital, and a much better outcome for that individual. So this really was a amazing experiment in collaboration between the CCOs themselves and between the CCOs and the OHA, and it was a partnership for innovation, and I think we need to keep that in mind. So in the first 5-year waiver period, the state operated within that 3.4% growth cap. This is in the depths of the Great Recession. We're starting to come out of it. We expanded enrollment by 385,000 people with the ACA in 2014. All the CCOs met their quality and outcome metrics. We paid back the $1.9 billion loan, and we realized a net cumulative all-sum savings of about $1.1 billion. So what we demonstrated with those CCOs, particularly in those first 5 years, that a locally designed, locally operated, locally accounted delivery model can maintain quality, expand access, and reduce costs. So if you look at the trend, this is sort of the cost savings grow, the delta grows over time, and we did that not by cutting benefits, not by cutting enrollment, not by cutting quality, not by cutting what we did for providers, but by forcing the delivery model to actually find efficiencies and create those incentives for investing in prevention. So the two keys to this success, I would argue, are first of all the flexibility. The flexibility of the CCOs to make investments that they feel are really important. Some of those investments won't have a billing code. An air conditioner doesn't have a billing code, right? The whole idea was to give you that flexibility. You would not be penalized for those investments in the way the budget was put together. And the second one was, in fact, the global budget, a true global budget. We were going to give the CCOs a global budget and some outcome measures, and hold them accountable to quality and outcome, but not micromanage how they spent those dollars. So today, I think our framework of collaboration is facing 4 main challenges, not to mention the current challenge going on in Washington, D.C., which we can come back to. But these 4 challenges, first of all, was the relationship with the Oregon Health Authority. I think it's essential that we try to repair that relationship, which is migrated, I think, from a partnership and collaboration to a much more top-down regulatory and sometimes punitive approach that has undermined that spirit of collaboration that's so important for this. And the time and energy that it requires to meet this growing regulatory superstructure takes resources and time away from direct patient care and innovation. So I think it's important that we honestly put that on the table, not in a confrontational way, but hopefully with a sincere desire to balance the necessary accountability with the flexibility need for innovation. And that is what's going to allow us to create a 5 or 10-year vision for what we want the Oregon health system to look like, which we don't have today. So there's no context in which to judge the hundreds of little healthcare bills that go through the legislature. They're not part of any larger long-term vision, which is, I think, really, really important. So the second thing is we've moved away from the global budget back to traditional rate setting, right? And I think we need to make a very high priority of working with our federal partners to go back towards that kind of true global budget. One that encourages innovation, one that encourages reinvestment in the community. And I think the rate setting methodology has to include a consideration or count the efforts we have to improve health outcomes, the efforts that we have to improve community health, the efforts we are making to build network capacity, and also the anticipated utilization of new services that might be mandated by the legislature or by the Oregon Health Authority. We have a bill in to do that. I don't know its fate, but there's one floating around out there. I could give you the bill number, but it deals with both the list and the. So the third one is the list, and I'm going to talk about just that minute because there's been a lot of talk about that right now. So let me sort of, for the record, give you the little background on that. So when the current waiver was renegotiated in 2022, agreement was reached between the Oregon Health Authority and CMS to move the prioritized list from the waiver into the state plan amendment. Now, it's still not clear to me what problem they were trying to solve by doing that, but what is clear to me is that there is nothing in the transmittal letter that says the state has to stop using the prioritized list to build a benefit package, which we've been doing now for over 30 years. As I mentioned earlier, one of the problems is there's just no institutional memory in either the legislature or the health authority about why we have the list, what we were trying to do with that list. And the fact is, Oregon remains the only state in the nation that has this kind of transparent, accountable, public, evidence-based process to develop our benefit package. In fact, other states that don't have this process, when Big Pharma or anyone else who wants their treatment covered, they go in behind closed doors and they beat up on the Medicaid director or they contact the chair of the relevant committee until they cave in. That's not public, that's not transparent, that's not accountable, and it's not evidence-based. And we should not let go of a prioritized list unless there's a really good reason to do that. And to me, so far, the reason hasn't been made apparent. Yeah, I'll leave it at that. So the last thing I want to talk about briefly is just this notion of the relationship between CCOs and community health. So, one part of the original vision was that CCOs wouldn't just be medical providers, they would also look at community health. And that was, I think, an explicit recognition that most of the things that affect lifetime health status don't occur in the medical system. They occur in the community and very often in the very earliest years of life. So we know from this growing body of epigenetic brain science that maternal stress and poor nutrition before conception and during pregnancy can alter the genetic expression in the unborn child, which increases the risk of poor cognitive functions, learning disabilities, behavioral health and substance use disorders, and the early adult onset of many chronic illnesses like diabetes and cardiovascular disease. So while the CCOs, what the point is, we got to invest a lot earlier. I mean, 85% of the cost in the healthcare system is chronic disease management. If we don't start slowing that on the front end, we're never going to be able to get ahead of this. So while the CCOs are tasked with addressing community health, they can't do it by themselves. They need partners. And the partner I think they need the most is the early learning hubs, which a lot of people have forgotten. We created intentionally at the same time in 2012 as the CCOs. And their mission is to bring together multiple community partners and align resources and services to better serve very young children and their families. They were supposed to be the connection between the clinical model and addressing the upstream social determinants of the health. So we've started working on that, and in 2022, an organization, a 501c3 public benefit corporation, was created called the Oregon Health and Education Collaborative. I have the honor of being the board chair. Currently, it's got education and healthcare leaders from around the state, and our flagship project is called the First 1,000 Days Upstream Initiative. And in spring of 2023, we sent out a letter of interest for communities to see if they were willing to essentially ask the question, if anything were possible, if we weren't constrained by politics, resources, turf, egos, how would we ensure that every child in our community has an equitable opportunity to succeed in that first 1,000 days of life? And we picked 6 of these we call them design pilots. And for the last year, they've been developing what are called child success models. Like the CCOs, locally designed, locally directed, locally controlled to make sure those kids get those services. So there are 5 of them: Yamhill, which also is the early learning hub, some of you probably know that, Marion Polk, Lane County, Southern Oregon, and Blue Mountain over in the Northeast Oregon. And so your organization funded the design pilot over there in Blue Mountain. And we have a bill, it's Senate Bill 1167. The chief co-sponsors are the Majority Leader of the House, Ben Bowman, and Senator Reynolds, who shares the relevant she's got the omnibus bill. We had our first hearing on Tuesday this week. We're asking for a little under $12 million to resource. I think the number for Blue Mountain is around 3.5 or 4, to resource these as demonstration projects, to demonstrate to the state the outcomes we can get if we start making these investments early in a way that is locally owned and locally controlled. Each one of these is unique to their very regional community. So that to me is very exciting. To me, that's the next big step in health system innovation, is to start to keep people out of the health system in the first place. And if you're on a global budget, that's not only a humanly a outcome important, but it's a economically important venue as well. So let me just wrap up by saying, we've come a long way together. I've been on the journey. Some of you are probably not even born when we started on this journey. But we've reached this point together, I think, because our approach to health policy in Oregon has always been based on 3 things: collaboration and cooperation and bipartisanship. And that was reflected in the votes of the Oregon Health Plan and the CCOs. The Oregon Health Plan passed 30-0 in the state Senate and 57-1 in the House. The bill that created the CCOs, at a time when the Democrats had a 1-vote majority in the Senate and the House is divided 30-30, passed the House 57-1 and the Senate 22-7. We've demonstrated that health policy doesn't have to be an ugly bipartisan issue, and that if you engage people at the community level, if you respect one another and figure out a way to agree to disagree, you can really move mountains. So it's my hope that this context and this history of the development of our Medicaid delivery system and care model will help us guide the upcoming debate over the future of health policy here in the state of Oregon. I am, when I think about this journey, I'm obviously not going to see the end of it, but it was just one of the greatest thrills of my life to be part of it. I think of a passage from The Sound of Mountain Water by the great Western writer Wallace Stegner. It's a book of essays. You'd probably like it. He was talking about the West in this quote, but I think he could well have been describing the Oregon story of health system transformation. When it fully learns that cooperation, not rugged individualism, is the quality that most characterizes and preserves it, then it will have achieved itself and outlived its origins. Then it has a chance to create a society to match its scenery. That's us. Thanks. All right. That's all I got.
Any questions?
Yeah, absolutely. Yeah.
Ask one?
Yeah.
Going back to that, did you say 27 in the emergency room? Was that how? 27?
I was 27 years old.
So that.
Making a balloon chicken for a child.
So that long journey that you've been on through the work you did there and in legislature and all the things, what would you change? If you could change something in the system where we are today that you created through the CCOs, through being an emergency room physician, is there any one thing that, looking back to all that experience, you would change?
I guess there's something we could have done better.
Yeah,
No. I mean, fair enough. I mean, the original vision for this was to get this working in the Medicaid program, but this was never to be just a Medicaid reform structure. The next step, we wanted to move this model into the small group and individual market. We wanted to get a Medicare waiver. And the only people you can't pick up then are the self-insured folks. But the cost shift's going to go right to them. I mean, it's going to change the political dynamics. We didn't do that. What I was going to say is that, let me just use an analogy. Our land use planning program, which some of you may or may not be familiar with, was put in place 50 years ago. And that's why if you fly over Washington County and Clark County, you see a lot more open spaces down here and farmland and trees and farms and stuff. That was passed by the legislature. Governor McCall was credited with the vision. What made that work was a group called Thousand Friends of Oregon. It was a grassroots group that litigated and reminded people of how important that is to it's part of the DNA. It's why Oregon looks like it does today. I had hoped that the CCO model would be that 1,000 Friends of Oregon, that these local entities would take root. And I got to tell you, and I say this not just because I'm here, but Eastern Oregon is one of the most incredible models. And you know, having spent a lot of my life in rural Douglas County, you know, there's a kind of community in a rural community that's different than in a large metro area. But you folks have followed this to the T. You know, you've got a community advisory committee in each county. You don't have to do that. You've got this LLC model where you've got these equity partners that all work together. You can move money around, and I think you have kept the vision alive. You know, if I had to pick one that I think epitomizes this, and it's due to the leadership of this group, every one of you here. You know, I remember the story of Robin here, a slick city boy driving his, I don't know what you were driving, but was probably not a pickup truck, over to Eastern Oregon and say, I'm from the west side, I'm here to help explain you how this works, you know.
I work for an insurance company.
Exactly, I work for an insurance company, right? And, but you know, he won him over. And it's just, you know, I really believe, my whole political philosophy is based on the belief that if you can develop relationships with people that are beyond, look, see people beyond the politics, beyond the labels, and find something bigger than yourselves that you all want to work on, it's amazing. And you guys have done that, so thank you for that, for sure.
Can you talk a little bit about what's going on right now in the federal government? And I mean, you've written some legislative language that
Yeah.
is getting some traction.
I don't know if it's getting traction, but
It's
so
drawing attention.
yeah. So the ECO Northwest in 2018, we funded a study that projected if every state in the country did what we did, including an proportional upfront investment, and got the cost savings, the 10-year cost savings nationally is about $740 billion. And that's after paying off the initial investment. So it's doable. And the problem we're getting, and I have to talk to the congressman, I'll try to talk to him tomorrow. He's been socializing it. I don't know, I'm not privy to what goes on. And there's a wing of that caucus that probably just wants to sort of slash and burn. But I've been getting some pushback from Democrats. You know, their message, and I used to be on the board of Families USA, just stepped off in December, it's no cuts to Medicaid, period. I think that's the wrong message from a policy standpoint, and I think from a political standpoint. Because for the last 3 election cycles, the Democratic Party has been telling people that all our institutions are working just fine, which doesn't line up with the real life experiences of hundreds of thousands, millions of people who just are not making it today, right? So how about saying, let's defend the need for the institution, in this case, a public program for vulnerable Americans, but let's make that program work. Let's not prop it up by making the national debt bigger. Let's prop it up by making the program better to serve the people who are on it. And, you know, I don't know. This is caught up in a much bigger game of which I am not, blessedly not a part. And it's about the next election cycle and all that stuff that they do back there. So it's in play. I don't know what will happen to it.
And one comment that I'll make is you're putting a global budget was really a key to the success of the CCOs, but a lot of people, he doesn't realize what a global budget means.
Yeah.
What a global budget means is not just a chunk of money that you get. It means you're at risk 100% if you spend more money than you're given in a global budget. And that, I remember I was driving back from Pendleton when we got the call that we were officially a CCO, and I was excited for about 10 minutes.
Were you running at the time?
Yeah, I was being chased.
Yeah.
And I was panicked for the rest of the drive home because we have all these cost-based hospitals. How are we going to be able to do this under a global budget? We are at 100% risk. I don't think the state even really realizes that. If they realize that, they might look at the finances a bit differently, because if we exceeded our money, it comes out of our pocket.
You know, this was a huge betting on the come moment. So the way we did this is a little inside baseball. So we didn't have any money, right? And so I front end loaded all of our Medicaid money into the first year of the 2-year biennium. And that took that 39% cut down to, I think, 9 or 10%, which everyone said we can probably live with that. So we had a $600 million hole in the second year of the biennium. And we went back and worked. We had to get that money. I remember George Brown was CEO of Legacy. I said, I'm going back to get the money. He says, well, come back with the money or on your shield. Yeah. But it was, I just have to share this. One of the most beautiful moments of my life was when when we got that waiver. I was in the old Ebbets Grill. We were waiting for a call from the Secretary of HHS, Sebelius, to say we were going to get it. I got the call, and I went outside there. It's right across from the Treasury building, and it was May 2nd, and the sun, really soft DC, and the sort of pink glow in the Treasury building, and I started to cry. And the next morning, I got up really early and started calling people from a Starbucks right next to the HHS building, called George Brown. I called everybody I knew and said, we got the money, we got the money. It was just amazing. And we all did it. We all did it. We had a really good program, and we need to keep it. We need to evolve it, but we shouldn't walk away from the basic cornerstones.
At the CCOs, so the parental environment, working with OHA, you brought up some of the things, right? The relationship you brought up. How would you suggest the CCOs start working with the state again to try to?
What I think would be really useful, and I don't know whether it'd be great if it came from the agency, but it could come from the CCOs. I think it would be great if they had monthly meetings with the director. Not the deputy director, but maybe the Medicaid director, but definitely the director of OHA. Monthly meetings, and without an agenda, because we started that, and we met every month. And at the beginning, there was this wringing of hands. Oh my God, how are we going to do this? And then at about the third meeting, someone in Coos Bay would say, "Well, we're having this problem," and someone from Central Oregon would say, "Well, I got the same problem, but listen, we figured out how to work on it." And it became this just inspirational became a community, right? And I just think that relationships are at the basis of everything. And part of it is you have these Zoom calls where you're being talked at, not listened to, and just no real agenda. At least maybe the first hour there's no agenda, then maybe you have something on it. I think that would go a long way to fix this. Yeah.
You talked about getting the waiver passed, and we kind of glossed over that a little. And you mentioned getting the call. And I wonder if you can talk a little bit about how you got the original waiver approved.
Yeah.
Seemed a little easy, but I didn't want to.
So I got to tell you, so if simply get just a minute here, I want to talk about the OHP waiver, which is even a better story, but the CCO waiver is pretty good too. So, this was denied to us by George Bush Sr. in August 2nd, 1991. He denied our waiver. And so later that month, I got my office. I'm Senate President at the time. I should have a picture of this. I get a call from the governor's office in Arkansas, and some guy named Bill Clinton wants to stop by and hear about the Oregon Health Plan. And I didn't realize he was running the DNC and he was getting ready to run for president. He was really out here to see Governor Roberts. So he comes by, and I've got this OHP 101. You saw some of the slides. And he's sitting there. It's after lunch. My projector's kind of humming, blinds are down, and I distinctly remember that the governor of Arkansas was having a lot of trouble staying awake. I mean, he was just kind of, some of you were doing that in the first part of my speech. I just want you to know I know who you are. So he next month, there's the 100th anniversary of Stanford, and so I'm down there speaking on healthcare, and he's down there doing his magic. And we ran into each other in the hotel, and he says, "Well, I'm going to be announcing that I'm running for president next month, and maybe there's a role for you in my administration." So I get out of office. He goes to the first debate in Washington University in St. Louis with Ross Perot, President Bush, and Bill Clinton. Sander Van Oker asked this question about the Oregon Health Plan, because Bush had just denied the thing. And Clinton sits up and spews out everything that I said in that meeting that I thought he was sleeping at. And I don't know whether it was just to fill a political moment or if he meant it, but he said, "And if I'm president, I'll give him the waiver." And so he gets elected. I'm down in San Diego. His wife, the organization that hated it the most was the Children's Defense Fund, and the chairman of the board was Hillary Clinton and a woman named Donna Shalala. Al Gore hated this with a passion. So he gets elected. Hillary's the first lady. Donna Shalala's running HHS, and Al Gore's the vice president. I'm thinking, oh, we're really screwed. And then Gore puts out this press release in March that says, "Well, I've had some criticisms of the Oregon plan, but I'll do whatever the president wants to do." And the next day he gave us the waiver. So that was that one. So the CCO waiver, we had this $600 million hole to fill. And so there's something called DSHP. Who knows about DSHP? Yeah. You find an unmatched state dollars in certain categories, and then the feds will match them. So we found a whole boatload. We were looking at I think it was 2.3 billion we were trying to get. And so we'd go back to CMS and Bruce and they'd say, well, give us all answer these questions and answer these questions. And so I had a friend named Scott Nelson, who's a no relative of his. Greg Nelson was the chief of staff for Valerie. I'm blanking on her name. She was like one of Obama's top advisors. So I got in to see her, and so we got this on the radar screen. But we were going back and forth with CMS, and so I got up to speed on all the questions that they were going to answer. And Jack Lew, who was his chief of staff, I got him on the phone, and I'd been practicing for 3 days to know all there is about DSHP. So I was able to answer all of his questions. And then I told Donna Shalala, we're going to come out and we want this waiver. And they kept waving us off. Did it 3 times. So finally on May 1st, I said, well, I'm coming back. And I tried to get a meeting with the president, and no one would tell me, but that was the day he was making that sobriety visit to Afghanistan. So he wasn't there, but we had this meeting in the old executive office building. Everyone's there, OMB, head of CMS, and Nancy Ann DeParle, who was the force behind the healthcare bill, ACA. I hear her heels coming down the hall, click, 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 click. She says, Governor, can I see you for a minute? She says, we're spending 3 hours a day on Afghanistan and 5 hours a day on a budget and 3 hours a day on the Oregon Health Plan. Yeah. And then she turned around and walked off. And we're sitting there, and I'm making my pitch, and they're not looking at me. I'm talking to them, and this guy comes in, I've never seen him before, he's passing this piece of paper around. I'm thinking, this is really rude. And finally he says, I think we got a deal. His name was Childress, and he was the president's fixer. He was one of these behind-the-scenes guys, and so it's clear that they've been working on this, and Obama had gotten directly involved, and just like Clinton did, and we got $1.9 billion. And we left that meeting on May 2nd, and we went over to the old Ebbets Grill to wait for the call from the secretary. So it was basically, the lesson there, I'm going on way too long and I'm sorry. The lesson there is that waivers are not administrative. I mean, we think if the last word is CMS, it's not. It's a political process back there, and if you can get the President of the United States or you can get the Secretary of HHS in your corner, you can get the waivers done. So I think there's actually opportunity right now if we wanted more flexibility. I mean, it's, I know the head of HHS, his father was the reason I got involved in politics. He's a far cry from Bobby, but I don't think he's an ideologue. I think we could make this work if we needed something. But we have to have our act together. That's why those meetings, I think, with the OHA is really important.
So one last question. So speaking of how you got into politics, can you tell us about how you got into medicine and how you became an emergency room physician and how that morphed into politics?
Yeah, so this is not, my life has not been linear. So I wanted to be a naturalist. I want, like Dr. Doolittle or, William Beebe. And I dissected animals and I chased butterflies, and my parents, God bless them, were really tolerant of me. And so when I was a senior in high school, I built this, it's called a perfusion apparatus for the Northwest Science Fair that kept isolated organs alive outside the body. And so you could study them without other hormonal influences. So I borrowed my sister's pet rabbit, whose name was Clyde, and I surgically removed its left kidney. And it lived for 5 more years. My sister still hasn't forgiven me. And I put it in my heart-lung machine. And I had to get, this is a horrible story, I had to get blood for this thing. So I would go out to Falkenstein's slaughterhouse in West Eugene at the crack of dawn, and these cows were out there very nervous, and they would shoot the cow and haul it up and cut its throat, and I'd dash in with my little Erlenmeyer flask, and get the blood. And I was already considered a nerd, and when I would arrive blood spattered to first period math class late, I was considered a dangerous nerd. I won the science fair, so I was very excited about this. And so I went to Dartmouth College, and we got a grant from the National Heart Institute and built this heart-lung machine. It was actually very cool. So I was going to go into biomedical research. So I went to medical school to learn more about human anatomy and physiology. I wasn't interested in practicing medicine at all. I was a terrible student. I led a demonstration against the war in Vietnam with black armbands and white jackets, and not a favor of the dean up there. That's the whole nother story. I managed to get into my senior year, and I took a rotation in the ER in the old Multnomah County Hospital. I think they call it North Hospital now, and loved it. So I went off to Denver and did a rotating internship and took all my electives in Denver General, in the big knife and gun club down there. And it happened in '68 before I went to med school. I was in the lab working on that heart lung machine, and I had my little transistor radio on and heard the news that Dr. King had been assassinated. And I remember just being, was totally apolitical, and I remember standing there putting my screwdriver down very carefully and just standing there, just feeling these emotions that I can't. So I went out and got involved in Bobby Kennedy's campaign. And he gave a speech the very next day that you should actually look up. It's the speech he gave to the City Club of Cleveland on April 5th. And it was about the violence of institutions. And so I got involved in his campaign, and from the moment he got shot in Los Angeles on June 6th, I knew I wanted to go into politics. So I went to med school feeling like I should be out on the streets, and was a little bit out on the streets, but I always kept that dream alive. And then I ran in '78, right after I started practicing in '74. I thought of running in '76 and decided I couldn't possibly get elected from a conservative place like Roseburg. And then I decided, well, maybe I can convince them to like me. And it was one. This is an example of community. They didn't agree with me, but I sewed them up. I delivered their babies. We drank beer together, we fished together, and there's that trust and the power of relationship so that's is very, very circuitous. So politics is my big goal, public policy is my big goal before I got into healthcare medicine. It was just a fluke, this could never have happened if I hadn't, been practicing medicine and in the legislature at the same time. So there's a lot of circumstance involved, but it's been a great ride.
Accepted, and we're all very lucky that that's the way it
Great ride. Yeah.
goes. Thank you.
Yeah. Thank you.